Welcome to this Let's Talk Medicine podcast from the Australian Doctors Federation. This episode is entitled From Chronic Disease and Death to Chronic Wellness and Wealth. The way we nourish our bodies and minds is vital for healthier, happier lives. A healthy nation not only reduces the personal and economic burden of disease, but also facilitates productivity and so shared wealth creation. According to the Australian Institute of Health and Welfare, in 2024, Australians lost 5.8 million years of healthy life, caused primarily by being overweight, including obesity, this having overtaken tobacco use as the major cause of harm. So let's talk about causation. Across the fast food and takeaway service industry, in Australia in 2023, total revenue was a staggering $23 billion. Governments are unwilling to tackle such a massive industry, despite the associated detriment. Drug companies and retailers also profit handsomely from the overweight and obesity epidemic, sustaining it with political donations. Governments thus fund costly disease interventions rather than cost-effective prevention. This wasteful approach means less money for vital areas like education, housing, defence, and accessible primary health care, whilst leaving future generations to shoulder massive debts incurred by today's avoidable chronic diseases. Recognizing that governments will not protect us from our addiction to harmful foods, only we can act to protect ourselves, our families, and our nation. Knowledge is power. This podcast will give you the knowledge, the motivation, and the power for change. All of us must shoulder the responsibility to transform our nation from one burdened by chronic disease to one that is a trailblazer for chronic health, wealth, and wisdom. I am Dr. Chris Davis, physician and former parliamentarian. To inspire and empower us with his life-changing wisdom, we now go to Professor Luigi Fontana, Director of the University of Sydney's CPC-RPA Health for Life program. The chair of the Australian Doctors Federation, Dr. Agnello Iannuzzi, also contributes his invaluable and wide-ranging insights as a leading general practitioner. We begin with Professor Fontana.
So let's talk about Australia. 25% of children, so these are governmental data, 25% of children overweight or obese. 54.4% of men and women aged 25 to 34 overweight or obese. 82.9% of men in Australia aged 45 to 54 overweight or obese. Obesity, especially central obesity, is a major cause of type 2 diabetes. There is a very strong relationship between type 2 diabetes and obesity. But not many doctors know that well before you develop type 2 diabetes, you have prediabetes, and well before you develop prediabetes, you have high normal glucose. And when your glucose starts to increase, basically is because you have insulin resistance. And if you have insulin resistance, you have compensatory hyperinsulinemia. So basically, you are secreting more insulin to try to overcome this insulin resistance. But this hyperinsulinemia is driving aging, cancer, and dementia, and all the diseases of aging, because we have published in Science and other major journals that the most important pro-aging pathway, pro-cancer pathway, is the insulin IGF-1 mTOR pathway. So if you have excess insulin secretion because you are insulin resistant and because you have abdominal obesity, you have visceral fat, you are aging faster, and your probability of developing cancer, dementia, and many other cardiovascular conditions is much, much higher. But, as doctors, until someone comes to us with a diagnosis of type 2 diabetes with a high glucose, we are not treating them because there is no medication to be prescribed, because by definition, to prescribe a medication for type 2 diabetes, in most cases, you have to have full-blown type 2 diabetes. So if they have, high normal glucose or at the beginning of pre-diabetes, okay, you should lose weight. But that's it. And so the system like that, it becomes unsustainable. And so that's why, one of my mantra, as you know, now I'm the director of the Charles Perkins Center RPA Clinic and the Health for Life program. One of my mantra is, let's change conversation from treating chronic disease to promoting chronic health. Because now we know, of course, the knowledge can be definitely, with the advancement in molecular biology, AI, we're going to have probably in the next 5-10 years a better understanding of the molecular metabolic pathways. But already now in 2025, we can prevent many of the most common chronic disease we see in our hospitals.
So you're saying not only are these things preventable, perhaps they are also reversible, would you say?
Yeah. I mean, from type 2 diabetes, we know that from the UK direct study trial that published in Lancet Diabetes Endocrinology that, is a dose dependent. So people with type 2 diabetes that they lose less than 5 kilos, only 3.2%, they go in remission. But people that lose more than 15 kilos, basically 86%, they are in remission at 1 year. For fatty liver disease, there is a Cuban randomized clinical trial. People with NASH, those who lost more than 10% of their body weight, 100% resolution of steatosis, and 80% they had a regression of fibrosis. So basically, they did liver biopsies, and there was a regression of liver fibrosis. And for cardiovascular disease, we know from studies with statins and antihypertensive medications that the volume of the plaque can be reduced by drastically lowering cholesterol or blood pressure. For cancer, no. I think, well, as you know, especially for breast cancer and prostate cancer lately, I'm reading that these lesions that are low risk, like a Gleason score 6, or these in situ breast cancer, that they are very low aggressive. There is more and more consensus that they shouldn't be surgically. They should be just watchful.
Conservatively.
Watchful waiting. And so I think, as technology improves, I think, we're going to be able to say, okay, your prostate cancer is a Gleason score 6, has this imaging and molecular phenotype. So just change your lifestyle, so, you have less inflammation, less IGF-1, less insulin, and just let's keep an eye. Because, the surgery can induce, as you know, urinary incontinence, impotence, and, all these problems. And so why you should cause harm if someone has a low-grade, low-aggressive tumor, and the same is for breast and other cancers. So I think, we're getting there. The message that I have for my colleagues and for the scientific world is that we have the knowledge in 2021-25 to prevent many of the most common chronic disease, or at least, to markedly reduce the risk of developing them. And we are just basically treating the symptoms. It's like, if in Australia, that is a very hot, dry summer comes and you don't do your job before, you don't clean the wood, you don't remove, the dry, the dry, branches, stuff like that. You don't do the clinic. Then you just wait, for the hot summer to come. And then I say, there is a fire here, a fire there, a fire there. And then, like in California now, basically, then the situation goes out of control and it becomes very expensive and very deadly.
Okay. So to prevent these problems or to deal with these problems before they lead to greater problems, you've mentioned calorie restriction is one way. You've talked about the need to reduce inflammation and promote insulin sensitivity. There seems to be at the moment a huge push towards finding quick solutions to these things via medications and in some instances even via surgery such as gastric band surgery. What are your views on taking a medical or surgical approach versus taking a lifestyle approach?
Well, it depends. If you have someone who is morbidly obese and with metabolic abnormalities, probably that's it's not the only solution, but probably is the more practical. Because if you have a BMI of 35 or 40, maybe you already have impair your joints, and so you cannot exercise properly, and it becomes difficult. So I think bariatric surgery and some of these GLP-1 receptor agonists, this new medication like Ozempic, I think they have a role, but they are not again a magic solution, because if you lose weight with calorie restriction, either with diet or with this pharmacologically induced calorie restriction, because GLP-1 receptor agonist or bariatric surgery is basically a surgical or pharmacological induced calorie restriction. Yes, you lose weight, but you lose muscle mass. So basically you are increasing the risk of sarcopenia and osteoporosis as you age. Because skeletal muscle is an extremely important tissue for glucose metabolism and insulin sensitivity, you increase the risk of glucose, disruption long term. Another major problem is that if you are eating an unhealthy diet and then, you just do pharmacological induced calorie restriction, you're eating less of an unhealthy diet. And so basically the consequences on your vitamin, mineral, then, you say, I give you a supplement, a multivitamin. But the fiber, the role of fiber, for example, in gut health, gut permeability, the production of microbial metabolites are very important for the immune system, is well known. And therefore, if you have a low fiber diet and you're eating less because you are on a GLP-1 receptor agonist that is suppressing your appetite, your risk for malnutrition is increasing, and so long term it's a problem. So I think it's not the solution. It's one of these shortcuts, but think about it. Yes, with antihypertensive statins and anti-diabetic medication, we have reduced cardiovascular mortality. Cardiovascular disease in 2025 are still the leading cause of morbidity, mortality, and healthcare cost, despite, now how many 30 years or 40 years of statins. Now we have the PCSK9 inhibitors, we have, different type of antihypertensive. Now we have new anti-diabetic medication, and yet, the number of people that are going to the hospital with an MI or heart failure. Now there is, this new form of diastolic heart failure that is more obesity related, microcirculation related, is increasing because it's increasing the obesity. So they have normal contractility, but they have this diastolic heart failure is increasing big ways, and stroke, different type of strokes, dementia, white matter disease, and dementia is also vascular dementia that I think, is overlapping with Alzheimer's disease, is also increasing, becoming probably one of the major problems of the next few years, because, once you start to have so many people with dementia or with cognitive impairment in a society, in a family, is disruptive. Can you imagine, you have, your parent, one or two with dementia, unless you are well off, who's going to take care of your parents who are demented?
Yes, well, I've been in practice now for about 30 years, and sadly I'm seeing more and more dementia at a younger age. And not all of it can be put down to toxins, and not all of it can be put down to head trauma, and one has to wonder whether diet's got a big role. So you've mentioned that surgery and medications could be a good way to maybe get on top of something quickly, or a temporary solution, or a way to start. When it comes to calorie restriction and diet, one of the common things we talk about, and you talk about this in your books, is intermittent fasting. Can you tell us a little bit about that and other methods of calorie restriction that can be applied?
Yeah, look, first of all, let me say that I recently published an article in the European Heart Journal. It's called the 10 Tips for Cardiac Health. In reality, as I said, it applies to all most common chronic diseases.
And we'll put a link to that in the show notes at the end of this podcast.
Okay. Thank you. And so basically, I hate, to talk only on one intervention because, it's a combination of interventions that, we have to practice. It's not only calorie restriction. It's not only exercise. It's not only sleep. It's a combination of factors that, they have to be applied to have an optimal intake, an optimal outcome without being disruptive in changing lifestyle. Because if you want to achieve weight loss and a major reduction in visceral fat only with calorie restriction, your calorie restriction has to be severe. But as I said, on the same time, you are reducing muscle mass, bone mass, and you are lowering resting metabolic rate. Instead of, if you do moderate calorie restriction with endurance, aerobic exercise, and resistant exercise, then it becomes more sustainable and more healthy because the exercise is preventing muscle mass loss and bone mass loss, is increasing metabolism and mitochondrial biogenesis, and therefore the combination of calorie restriction with optimal nutrition and different form of exercise is become more sustainable and more healthy. But anyway, let's go back to calorie restriction. So when I started to work on calorie restriction, as I said, in 2001, there was nothing in humans. And so when I went to WashU, what we did, we said, do humans adapt to calorie restriction as long-lived animals do? And so we did, most of the most important pioneer works on calorie restriction in humans, and we found, yes, that most of the metabolic, molecular, physiological, cardiovascular adaptations that we see in long-lived animals occur in humans as well, with few exceptions. And then at one point, intermittent fasting started to become prominent because some scientists, instead of doing chronic calorie restriction where you reduce by 30% caloric intake on a daily basis, they say, why we don't start to do intermittent fasting? So one day you feed the animals, one day they fast, one day they feed, one day they fast, okay? And so they found that, intermittent fasting in animal models was more or less equivalent, not the same, but, equivalent to chronic calorie restriction with good nutrition, with all the vitamins and minerals. Because let me restate, if you do calorie restriction with malnutrition, if you eat half pack of French fries, half hamburger, and half soda, this is calorie restriction with malnutrition, and you're going to die earlier of malnutrition. So the problem is that, I did a study when I was in US on intermittent fasting, the 5-2 diet. The 5-2 diet that became basically viral was because of me. Because, Michael Mosley, he insisted to come to interview me and Walter Longo in US. He came to me, he did the interview, he produced the documentary, the BBC documentary, Eat, Fast and Live Longer, and that documentary basically opened this story about fasting. He had the book ready, the 5-2 Diet book. Basically, he became like a fad because there was no data in humans, okay? There was only animal data. And so a friend of mine who has a foundation in US, he funded one of my studies on intermittent fasting where we fasted people 2 or 3 days a week. If their BMI was between 24 and 28, they were fasting 2 days a week. If their BMI was between 28 and 35, 3 non-consecutive days per week. The fasting was vegetable only, so I didn't want them to count calories, so they were allowed to eat non-starchy raw or cooked vegetables dressed with 2 tablespoons of olive oil per day with vinegar, lemon, and salt and spices. And to make a long story short, basically in 6 months of this intervention, this randomized clinical trial, we achieved an 8% weight loss. That's good. And a 16% reduction in body fat by DEXA. The primary outcome of the study was C-reactive protein, high-sensitive C-reactive protein, no change. Then, we measure a number of cytokines and chemokines, no change. We did GTT to see glucose tolerance, insulin sensitivity. There was a tiny improvement in glucose tolerance and a tiny improvement in insulin sensitivity, nothing to what we have shown in calorie restriction and aerobic exercise that both have major improvements. So why? A 8% weight loss with 16% reduction in body fat didn't translate into a reduction in inflammation and improvement in glucose insulin, as we have seen in calorie restriction and exercise. I believe, and there are other data supporting my hypothesis, that these people, during the feasting days, they were eating the typical unhealthy American diet. So 5 or 4 days a week, they were eating the American diet, and then 2-3 days a week, they were doing the vegetable fasting. And so there are more and more data showing that the metabolic response to weight loss are basically shaped by the composition of the diet and therefore of the gut microbiota, shaping these metabolic molecular pathways. So you can lose weight, but if you are eating unhealthy food, the metabolic response to weight loss is not the same.
So the unhealthy food, I think, feeds into the issue of inflammation, doesn't it? Because calorie restriction is one thing, and that helps insulin resistance. But then, as you said, if on your feasting as opposed to your fasting days you eat rubbish, then you're going to trigger all of this inflammation in your body. Now, when it comes to inflammation, I see all sorts of ideas floating around now, and I must say in my clinical practice, in some ways I think it becomes a bit confusing. You see patients come in doing, say, a Mediterranean diet and they do well. You see others come in with a keto diet and they do well, and others with a carnivore diet and they do well. So it seems that there's more than one way to achieve success in achieving these low inflammation outcomes with weight loss. Is there, in your mind, more than one way to do this, or is there a preferable way to do this, or do you think that there's still a lot more research to do in these areas?
Well, look, there is definitely more research to do, no doubt about it. However, I can tell you what I think, based on what I know after 30 years of working in this field. Inflammation is just weight-related, visceral fat-related. So I think, these anti-inflammatory diets like the Mediterranean diet is a epidemiological artifact. And I'm saying that because I haven't published, we are just finishing to analyze the data. This is a study I did in the US where we randomized relatively healthy people to a Mediterranean diet. I was feeding them. So basically we provided the food, for 4 months to these people. And the Mediterranean diet was whole grains, legumes, vegetables, fish, no red meat, only poultry once a week, no ultra-processed food, refined processed food. And in the first 2 months of the study, I asked my dietitian to clamp their body weight because I wanted to study from a physiological point of view what happens when you improve quality without weight loss. Because typically, if you go on a high fiber diet, you lose weight. So I said, Kathy is the name of my dietitian. I said, Kathy, we should clamp their body weight. I want them to, after 2 months, to have the same body weight and baseline. So to achieve that, we had to overfeed 250 calories, healthy calories on average, to prevent weight loss. So message number 1, if you transition from a typical Australian, American, North European diet to a healthy Mediterranean diet, traditional Mediterranean diet, you're going to lose weight without counting calories. Number 2, The primary outcome of the study was C-reactive protein. No change in C-reactive protein. So if you don't lose weight, even on a high quality Mediterranean diet, inflammation doesn't change. And not only C-reactive protein, we measure TNF-alpha, interleukin-6, and many other interleukin-1 betas, MCP-1, and many other pro-inflammatory cytokines, no change whatsoever. Instead of LDL cholesterol was markedly reduced with this diet without weight loss. Then in the second part of the study, they fasted 2 days a week, and then we saw a reduction in C-reactive protein and improvement in glucose and insulin sensitivity. So the message is that for inflammation, weight loss is markedly more powerful. Then it's possible that if you cause damage to the gut and you start to have gut permeability, you can have, some immune activation. But in a healthy person, until the gut is not severely damaged, the gut permeability, body weight, body fat is the main driver of reduction in inflammation. So if you lose weight on a Mediterranean diet, on a keto diet, on a paleo diet, if you lose weight, your inflammation comes down and your glucose somehow improves, but it's not completely true that, and maybe we're going to discuss later. The problem is the long-term consequences of this diet, because if you look the short term, you lose weight and you have some metabolic improvements, including inflammation reduction. But let's make an example, the extreme. I take someone who is overweight, I put him on bread and water for 5 years.
Yes.
Everything improves, he's going to die of malnutrition, scurvy or pellagra or something else. So if you are on a keto diet, high in animal products, your LDL cholesterol increases. There is a paper just published in Nature Microbiology by Segata, who is now one of the leading experts in gut microbiota, showing that it was like 30,000 people across different countries, that a diet that is rich in minimally processed vegetable food has an advantageous type of gut microbiota, digesting fiber, producing short-chain fatty acids, so having less inflammation, less gut permeability. A diet that is rich in animal products instead of has an increase in bacteria that are digesting proteins, producing TMO, that is a metabolite that is increasing myocardial infarction and stroke independently of the classical cardiovascular risk factors, published in New England Journal of Medicine. And you have other alterations that are driven long-term by manipulating the gut microbiota itself. Think about it, what you feed to your bacteria, you are selecting different bacteria. If you keep them feeding high fiber, high vegetable foods, you are selecting bacteria that are specialized to digest those food. Instead of if you feed them a mainly high animal protein diet, you are selecting bacteria that are basically digesting this type of nutrients. And indeed, we published that in 2011 in Science with Jeffrey Gordon. This is now a highly cited paper. I think, he has like 3,000 citations where, we phenotype the stools of all the animals of the zoo of St. Louis and my people doing calorie restriction. And we found that the type of diet, especially the protein content and the fiber content, are two of the most important nutrients that are shaping the composition and function of our gut microbiota. So just to summarize, short term, if you lose weight, you have improvements. Even if you lose weight on cocaine or smoking, you have improvements when you lose weight, when you lose visceral fat. But long term, if you are smoking, that many people are smoking because smoking has centrally a suppression of appetite. It's easier, to keep your body weight low. So, but are you going to suggest as a doctor to someone to lose weight to smoke? No, because yes, it's long term. Smoking has consequences, and so I believe that the high protein diet, based on what we know on animal model of longevity, a keto diet that is high in animal products, because to be honest, most people who are eating a keto diet, they are eating mainly, animal food. Yes, yeah, maybe they eat more avocado, more oil, but in reality, the bulk of their diet is meat and dairy that is very rich in, again, L-carnitine, methionine, branched amino acids, iron, and many other compounds that, we know are driving some of the most important pro-aging pathways, including mTOR and other metabolites. So I believe that long-term keto, paleo, high-protein diet is detrimental to health and longevity. Short-term, like, the GLP-1 receptor agonist is okay. Maybe, you need a boost, to lose 20% of your body weight. You go on a GLP-1 receptor agonist. Maybe better if you do exercise in combination and you eat a healthy diet. You lose 20% of your body weight. Now from 100 kilos, you are 80 kilos. You are lighter, and therefore you can start to exercise better because you have 20 kilos less on your joints. And because you reduce your appetite, you can retrain your brain to eating healthier food. So in this sense, I'm positive, that, maybe these drugs are okay to start a new pathway, a new path of health. But I don't think, they're going to be the solution to our health crisis and the sustainability of our healthcare systems long term.
When it comes to exercise, you mentioned aerobic and then you mentioned resistance exercise. I guess it's important to do both. Lately, I've noticed there's a trend towards more promotion of resistance exercise and not so much aerobic, but you've mentioned a few times now the importance of doing both. What's the evidence showing there?
Well, in reality, there are 3 or 4 type of exercise, because there is also posture and flexibility. You know that in Australia, and not only in Australia, the most prevalent and more costly conditions are musculoskeletal conditions. So we're talking about billions of dollars spent every year for back pain, knee pain, hip replacement, back pain. And this is mostly due to obesity, because if you have a major load on your joints, these joints, they degenerate quicker, and bad posture. Because people, they don't exercise properly, they don't have a good posture, they don't have flexibility, and year after year, they have, basically this malposture that basically is becoming chronic and is causing all these diseases, then eventually necessitate opioids and anti-inflammatory drugs that are, as you know, they are very bad for the kidney and many other, so if you take chronically, ibuprofen or other anti-inflammatory COX-2 inhibitors, you are damaging the kidney, no doubt, and you are increasing the risk of gastric ulcers and, gastritis and stuff like that. But, if you have chronic pain in your back and your hip, in your joints, you need to do something, because otherwise it's devastating for your health, for your well-being and quality of life. And so there is endurance exercise, there is resistance exercise, and as important is flexibility, good posture, component of exercise, and they're equally important, and they have additive effects. So there are multiple review articles and papers showing that endurance exercise is the most powerful in improving insulin sensitivity and glucose intolerance, and in increasing mitochondrial biogenesis. And resistant exercise, instead of, is much more powerful in improving muscle mass and the bone, and in some way also to increase resting metabolic rate post-exercise. So the idea is that, if you do 2-3 times per week, 20 minutes, 3 times per week, Monday, Wednesday, and Friday is enough, to do some, weightlifting. You can use your body, you can use some elastic bands. You don't have to go to the gym, to do what it takes, to do some well-done resistant exercise for all your major muscle. In this way, you increase the fiber, the recruitment of fibers and the mitochondria within these fibers. And then when you do your half an hour, 40 minutes of running, biking, swimming, dancing, playing soccer, then when you increase your heart rate and the respiratory rate during your aerobic exercise in a sustained way, you are burning calories, and through the GLUT4 mechanisms, you are improving glucose tolerance, insulin sensitivity, you are producing BDNF that is important for dementia prevention and for memory consolidation and for depression, and many other myokines that are produced by our active muscle. But so what I'm saying, resistance and endurance exercise, they have complementary additive effects. And you have to do both with the posture flexibility to avoid basically disruption of your joints and degeneration of your joints.
For those of you who haven't met Professor Fontana before this podcast, he's published a number of books which we will reference in the show notes, and he also posts a lot of very interesting things on social media, particularly on LinkedIn, pointing out not only his own research, but other interesting research from around the world relating to these topics. Professor Fontana, what about sleep? You've mentioned sleep a couple of times. What should we as clinicians and members of the public be thinking about when it comes to sleep and how it contributes to healthy aging?
Look, sleep is a emerging, very important topic. At the Charles Perkins Center, we have Peter Sisturi, a good friend of mine. Probably you know Peter as well.
Yes.
He's a leading expert in sleep. And with Peter, we have a lot of discussions. And so there is no doubt, every clinician knows that, OSA is an important risk factor for cardiovascular disease, hypertension, and developing cardiovascular disease. But more and more data, even published in Science, are showing that this sleep disruption, especially sleep fragmentation, is increasing beta amyloid deposition in the brain, both in animals and in humans. So basically, people who are sleep deprived, they have an increased risk of dementia through mechanisms that have been clearly shown in scientific papers published again in Science and other more important journals. Then, there are other papers showing that, the sleep deprivation is reducing leptin, is increasing ghrelin, therefore they play a role in the obesity epidemic. And as you know, one of the problems in our societies is this excessive use of iPads, iPhones, all these electronic devices with blue lights that is disrupting the circadian rhythm. And so people, they are obsessed, with, they get addicted, to the use, and even children, they get used to this, the use of these electronics that are one of the reasons why, we have this epidemic of sleep deprivation, sleep restriction, sleep fragmentation. But stress is also another major player. One of the other major problems in our society, we live in a very stressed society compared to 40, 50 years ago. I mean, when we were children, there was nothing, and, we were just, going out, playing like crazy. We were going back home and eating something, watching 5 minutes of TV, and then going to bed because you were tired, because you have been playing. Now, instead of, we're living in a society that is very sedentary, and even children, they have a lot of mental, emotional issues. I think, 50% of Australians in their lifetime, they develop some type of mental conditions. And so this is another important topic. I think, it's totally understudied in medicine, is that the role of emotional health and spiritual health in reshaping our way of living. I think, that, this obsession with becoming wealthy, becoming, successful, competition, money, Eric Fromm, to have or to be, there is too much emphasis on to have and very little emphasis on to be a real man. Society connection is becoming another major problem. Families are more and more isolated. People, they are more and more isolated. There is the loss of this sense of community, family. It is very important for mental health, for emotional health. And so all these problems have a lot of ramifications. The major one, I think, is when people they are stressed or depressed or emotionally unhappy, they need dopamine, boosts of dopamine to cope with this stress and emotional distress. And then can be food, can be alcohol, can be vaping, can be gaming, can be sex, anything that is boosting dopamine transiently. And then it can cause a vicious circle of basically unhealthy lifestyles. And therefore, I think, one of the goal of medicine and education should be, to reframe, what is emotional, spiritual, how we can use knowledge to basically reframe what are the objectives, the important objectives of a human being that is not just accumulating money and houses and cars and wealth and clothes and any object. Instead of is spending more time with their families, with their friends, having, solid human relationships, and also to build, this spiritual, emotional health with nature that has been part of our, thousands of years of human history. And only in the last probably 20, 30 years, we have been disrupting, this philosophical approach to life.
There's really been a shift in mankind or humankind from a lifestyle close to nature, close to other human beings, towards this atomized urban existence. And the more urbanized we become, the more stressed we become, and all the issues you've just touched on. And I think that's a very elegant way to conclude this conversation. We've looked at the diet and the physiological things that may impact in our death and in our healthy living, but it's really important to have a good life. There's no point living to 100 if we're not going to be happy, if we're not going to have any meaning to our lives, if we're going to wake up in the morning and not have anything to look forward to. So I really do appreciate those points you made at the end. And there's certainly points that you've raised consistently in your internet posts and even in your books. And I think as clinicians and as patients, and we're both, of course, it's important to keep those things in mind. Professor Fontana, this has been a fascinating discussion, and of course these topics individually can occupy many hours of debate and discussion, but I think from a broader perspective you've given us some guidance as to what we should be doing better as doctors and as patients, things that maybe we can be asking our doctors when we go to visit them. Are there any other points about healthy living and healthy aging that you think we've missed or we should think about before we close up?
No, look, as I said, as you perfectly summarize, is a huge topic. Will take, several hours, to dissect, all the, in my book, The Path of Longevity, the first book, I try to summarize for lay people. Unfortunately, it's not for doctor. Maybe for doctor is it
this book?
This one. Yes, maybe for doctor is a bit too elementary, but still, I think it gives. I think there are 1,200 citations, so all my sentences they are referenced, with top publications. So
believe me, I know many doctors have read that book and found it very useful. Don't you worry.
Thank you. So the final message is that we have the knowledge. In 2025, we have the knowledge to live in a fantastic world. So we really have the knowledge, to reshape, how we live and to change, to drastically reduce the risk of developing chronic diseases, to live a longer, healthier, happier, more fulfilling life. The knowledge is here. We have just to work to re-educate our children. I think, these topics should become part of the CV starting from year one of, in the primary schools. There is already, the PDHP that from this year is going to become called Movement and Health. That should be, 2 hours per week where, we should teach, this these concepts in a mechanistic way. It's not just exercise 150 minutes per week, by explaining to our children what happens when we exercise, what happens within our body, within our brain, within our muscle, what happens when you exercise, when you diet, when you do meditation, the cortisol, the sympathetic, parasympathetic nervous system, what happens. It's beautiful. So if it's taught well, it's important information for our children that, they can grow and understand how much is under our control.
That knowledge will empower them and motivate them, won't it?
Yeah, exactly. And as physicians, I think, we also have, apart from doing our job as best as we can, I think, we also have a role in changing our society. I mean, especially general practitioners, they have a huge role because, they are really in touch with the community they are serving. And so they can be role model, for a new society that is centered on promoting chronic health, emotional health, spiritual health, and environmental health.
Well, on behalf of the Australian Doctors Federation, Professor Fontana, I'd like to thank you for participating in this episode of Let's Talk Medicine. I think the Australian medical profession is very lucky to have you amongst us now, and we hope that you stay with us for many more years and keep teaching us how to be better doctors and how to live better lives. Thank you very much.
Thank you. Thank you very much for having me.